Good morning, ladies and gentlemen. Today I am going to cover two chapters in my lecture. The first will be the chromosomal disorders, and the second will be the Poikilodermatous syndrome. So first we will go through the chromosomal disorders. Chromosomal disorders may be due to abnormalities of chromosome number or structure and may involve autosomes or sex chromosomes. You all know that the somatic cells are diploid with a complement of 46 chromosomes, where the gametes, that is ova and sperms, are haploid with only 23 chromosomes. Numerical abnormalities that involve the gain or loss of one or more chromosome are called as aneuploidies. Chromosomal abnormalities generally cause multiple congenital malformations. The autosomal chromosomal defects. In the autosomal chromosomal defect, we are going to discuss two syndromes. The first and the most common is the Down syndrome. It is the most common autosomal abnormality with a frequency of 1 per 700 live births. It's quite common. 3 cytogenetic variants cause Down syndrome. That is Trisomy 21, chromosomal translocation and mosaicism. Trisomy 21 accounts for nearly 95% of patients with Down syndrome. Less common patient with Down syndrome may have 46 chromosome with either 21-22 translocation or 21-21 translocation. The clinical features. There is intellectual disability with IQ that is less than 50. The patients have small head, flat faces, increased intraocular distance, that is called as hypertelorism, depressed nasal bridge, flat occiput, broad and short neck, and small ears. There is narrow and upward and outward slanting palpebral fissure in 80% of the patient. There is small mouth with protrusion of tongue, that is macroglossia. Patients have short stature, broad short hand, feet and digits, and protuberant abdomen. There is hypogenitalism and congenital defects of heart or endocardial cushion defects. This is a typical cushingoid facies. Cutaneous manifestations of Down syndrome. Such patients have soft and velvety skin since early childhood. In late childhood, the skin gets dry. Xerosis is seen in 70%, atopic dermatitis in 50%, palmoplantar hyperkeratosis in 40 to 75%, and seborrheic dermatitis in 31%. There is premature wrinkling of the skin, cutis marmorata, and acrocyanosis. Frequent occurrence of bacterial and fungal infections and scabies. Other disorders associated includes elastosis perforans serpeginosa, syringomas, alopecia areata, vitiligo, psoriasis, and angular cheilitis. The second syndrome that comes in the category of autosomal chromosomal disorders is trisomy 81, also known as the Edwards syndrome. This syndrome is characterized by severe mental deficiency and characteristic skull shape with small chin and prominent occiput. There are low set and malformed ears, clenched hands with overlapping index and fifth finger with a single palmar crease. Cutaneous features include cutis laxa of the neck, hypertrichosis of forehead and back, and capillary hemangiomas. Death occur within months in 30%. Only 10% survive beyond the first year. And these infants show profound developmental delays. Sex chromosome defects. Among the sex chromosome defects, we are going to discuss the two syndromes, the Turner syndrome and Klinefelter syndrome. So first, the Turner syndrome. Turner syndrome is defined as the gonadal dysgenesis due to missing or structurally defective X chromosomes. The frequency of Turner syndrome is 1 per 2,500 female births. In some 80% of the cases, there are 45 chromosomes with an XO sex chromosome complement. Such cases are chromatin negative in buccal smear because they have only one chromosome, so it's not possible that this chromosome also becomes redundant. So Turner syndrome results in early spontaneous loss of fetus in over 95% of the cases. The diagnosis is usually made later as a result of investigation for short stature and primary amenorrhea. Clinical features: short stature, ovarian failure, that is elevated levels of luteinizing hormone and follicle stimulating hormone that confirms the ovarian failure. Pubic hair development is normal. Many patients have hypoplastic or hyperconvex nails. There are excessive number of nevi when compared with other family members. There is webbed neck and low or indistinct hairline. There is cubitus valgus, that is increased carrying angle. Chest appear to be broad with widely spaced nipples. This may be caused in part by the short sternum. In eyes, there is ptosis, strabismus, amblyopia, cataract. Hip dislocation and scoliosis, hypertension and murmurs, hypothyroidism, and cutis laxa, that is loose folds of skin, particularly the neck. These are signs in newborn. So this picture shows a typical short-statured web neck girl having Turner syndrome. The characteristic facial features: low hairline, folds of skin, then widely spaced nipples, wide carrying angles, multiple nevi, rudimentary ovaries. There is primary amenorrhea, poor breast developments, and coarctation of aorta. The diagnosis is made prenatally by amniocentesis. There is increased urinary secretion of follicle stimulating hormone that supports the diagnosis and confirmed by examination of buccal smear supplemented by chromosome studies. Treatment: estrogen replacement will allow the development of secondary sexual character, but does not seem to influence the stature or infertility. Treatment with human growth hormones may improve the ultimate adult height. Melanocytic nevi may grow more rapidly during growth hormone therapy. The second chromosomal abnormality syndrome is the Klinefelter syndrome. Frequency of Klinefelter syndrome is 1 per 600 male births. So it is also not an uncommon condition. In buccal smear, the nuclei are chromatin positive and indistinguishable from those of normal female, but in culture, there are seen to be 47 chromosomes with an XXY sex chromosome complement. The differentiation of developing gonads proceed along the male line, but testes fail to develop fully, and many seminiferous tubules are replaced by fibrous tissue. The testes are small and fail to produce adult level of testosterone that leads to poorly developed secondary sexual characters and infertility. The hair growth on the trunk, limbs, and face tend to be below average. Psychiatric disorders are common, but mental deficiency is not. Patients are tall, obese, and may develop gynecomastia. Patients with Klinefelter syndrome have an increased risk of developing leg ulcers, especially in combination with hyperpigmentation or atrophy blanchi. Some authors have attributed the cause of leg ulceration to venous insufficiency. These are the typical tall, obese male with sparse hairs and gynecomastia. The association of gynecomastia with small testes and otherwise apparently normal genitalia should suggest the diagnosis. It is supported by increased urinary excretion of gonadotrophin. The diagnosis is confirmed by chromosomal studies. Treatment testosterone replacement therapy will improve secondary sexual characteristics, but infertility is the rule, except in mosaic patients. Chromosomal mosaicism. It is the coexistence within an individual of two or more distinct cell lines that are genetically identical except for chromosomal differences, which can be total number, that is ploidy, deletion, duplication, or other chromosomal abnormalities between them. The mosaicism results from post-zygotic events caused by a mitotic error in some cell line during embryogenesis. The constitutional mosaicism often involves the skin and is expressed as patchy pigmentation, vascular, atrophic, or hyperkeratotic changes along the line of Blaschko. Now I am going to cover the second part of my lecture, that is the Poikiloderma syndromes. These include the syndromes in which Poikiloderma is a prominent and significant clinical feature. The first of the syndrome is Dyskeratosis congenita. Dyskeratosis congenita is a rare inherited disorder characterized by atrophy and pigmentation of skin, nail dystrophy, leucoplakia, bone marrow failure, and predisposition to malignancy. The nail changes are usually first to appear between ages of 5 and 13, and the nails are dystrophic and are shed. There are recurrent episodes of suppurative paronychia. Fine reticulate gray-brown pigmentation is most conspicuous on neck and thigh. This is actually the Poikilodermatous appearance of the skin. Small blisters and erosions of lingual and buccal mucous membrane are succeeded by irregular patches of white leucoplakia. Similar changes may occur throughout the GI tract and or urogenital mucous membranes. General physical and mental growth is sometimes retarded. Hair may be normal, but they are sometimes sparse and dry. This picture does not show the in true sense, the Poikiloderma, but it is something like this. that is the reticulate pigmentation on the neck, and Leucoplakia. All forms of Dyskeratosis congenita arise from mutation in genes involved in the telomere maintenance or protection. Telomeres are the structures that are composed of tandem nucleotide repeats and a protein complex at the end of chromosomes that are required to maintain the chromosomal integrity. It is determined by an X-linked recessive gene that is localized to XQ28. The hematological abnormalities. The incidence of bone marrow failure in Dyskeratosis congenita is high. Myelodysplasia and acute myeloid leukemia have been described. Bone marrow and stem cell transplant have been undertaken in such patients. Malignancy. The incidence of carcinoma in areas of Leucoplakia appear to be high and may prove fatal between the ages of 30 and 50. Other neoplasms that are reported include pancreatic carcinomas and Hodgkin's disease. Prognosis. The prognosis is usually poor as a result of blood dyscrasias and carcinomas. Individuals with TINF2 mutation and those with X-linked Dyskeratosis congenita 1 mutation tend to have most severe and early onset disease. Management. The aplastic anemia associated with Dyskeratosis congenita can be successfully treated by allogenic bone marrow transplantation. The granulocyte colony stimulating factor have been used successfully to improve the hematological parameters in short term. Retinoids have been reported to cause regression of lesions in Leucoplakia and may reduce the incidence of malignancy. The second syndrome to be discussed is the Rothmund Thomson syndrome, which is also known as Poikiloderma congenitale. Rothmund Thomson syndrome occurs predominantly in female 1.4:1, but determined by an autosomal recessive gene. There are reports of various karyotypic abnormalities that include trisomy 8 mosaicism. There is reduced DNA repair capacity and increased sensitivity to ultraviolet C have been reported. Skin appear normal at birth. The earliest lesions develop between 3rd and 6th months, but sometimes as late as the 2nd year. Cutaneous features include diffuse erythema that is succeeded by various combination of atrophy, telangiectasias, pigmentation, depigmentation, primarily on neck, trunk, face, and hands. So all these features come under the main heading of Poikiloderma. So it mainly presents as Poikiloderma on neck, trunk, face, and hands. Light sensitivity is a feature of many cases, and exposure to sunlight may extend the distribution of eruption on the upper trunk. In many cases, keratosis develop on exposed skin from adolescence onwards. Squamous cell carcinoma may develop in the keratosis. Scalp hairs are often sparse and fine and may be absent. Bilateral cataracts have developed usually between 4th and 7th year in about 40% of the reported cases. This is the reticulate erythema that is seen on the face and on the hands and forearms, and even diffuse poikiloderma involving the whole body. Physical development is frequently retarded. Most patients are of small stature and some are dwarfs. Skull may be small and features, bird-like features with saddle nose is seen. Hypogonadism of slight or severe degree is frequent, and incidence of hyperparathyroidism appear to be increased. The skeletal abnormalities include radial ray defect and recognized risk of osteosarcoma. The individuals of Rothmund Thomson syndrome are of normal intelligence. Management. Protection against sunlight is important. Careful supervision is essential to ensure detection of carcinomas. Low blood concentration of vitamin A have been found in patients with dyskeratosis, and one case lesion improved with retinoids. So this is worth trying. Telangiectasia, especially on the face, can be improved by treatment with vascular pulse dye laser. This is a differential diagnosis table of Rothmund Thomson syndrome, in which other syndromes with similar features are discussed. The Werner syndrome, which is a syndrome of premature aging, the skin changes are essentially sclerodermatous, and both skin and ocular lesion develop later than Rothmund Thomson syndrome. In Dyskeratosis Congenita, which we have discussed already, there is reticulate pigmentation developing between the ages of 5 and 13 years. That is most marked on neck, trunk, and thighs, not on the face. Atrophy and telangiectasias appear later, and nail changes are significant. In progeria, which is again premature aging syndrome, the child is small but otherwise normal during the first year. Thereafter, development is retarded. Scalp hair, eyes, and lashes are lost, and skin assumes increasingly senile appearance, but there is no poikiloderma. In Cockayne syndrome, there is light sensitivity, and conspicuous features are seen in the first year, that is telangiectasias and facial rash, but again no poikiloderma. In hypohydrotic ectodermal dysplasias, there is association of teeth abnormality, hair abnormality, or partial or complete anhydrosis. Skin is atrophic but not poikilodermatous. In xeroderma pigmentosa, only in mild form, there is only freckle-like or lentigen-like macular pigmentation. Again, no poikiloderma. In Bloom syndrome, there is erythema, but not poikiloderma. The telangiectasias of an irregular linear present at birth and feature of focal dermal hypoplasia, but in focal dermal hypoplasia, there is no poikiloderma. Acrokeratotic poikiloderma of Vieri. It's an autosomal dominant defect. The main clinical features are a vesiculopustular eruptions of hand and feet in infancy and childhood, extensive eczema from around 4 months to 5 years, a persistent poikiloderma sparing the face, scalp, and ear, and warty papules on hand, feet, elbow, and knees. That's why it is called as acrokeratotic. So the warty papules are seen on hand, feet, elbow, and knees, and poikiloderma also spares the face and scalp. Kindler syndrome, we have discussed in detail in epidermolysis bullosa chapter. It's an autosomal recessive disorder that is characterized by two features. The first is the neonatal blistering, which results neonatal blistering along with poikiloderma. Along with these two features, there is sun sensitivity, atrophy, abnormal pigmentation, and fragility of the skin. Poikiloderma spares the face, scalp, and ears. So the main diagnosis of Kindler syndrome is based on the poikilodermatous appearance of the neck and limbs, plus the easy tendency to develop blisters, especially at sites of trauma. Then poikiloderma with neutropenia, the Clericuzio type. Skin manifestations usually start in first 6 months with erythematous, eczematous, or ichthyosiform changes on the limbs. that subsequently spreading more centrally and being replaced by Poikiloderma. Photosensitivity is variable. Nails show an early onset of pachyonychia, and they may be associated palmoplantar keratoderma. In contrast to Rothmund Thomson syndrome, alopecia is not a feature, and unlike Dyskeratosis congenita, Leucoplakia is not a feature. The presence of neutropenia is variable and may be cyclic, and myeloid dysplasia and acute myeloid leukemia may occur. Recurrent airway infections with chronic cough, reactive airway changes are common. Otitis media is described. Affected individuals have short stature and facial dysmorphism. So this ends today's lecture. Next week, I am going to discuss the DNA repair disorders with cutaneous features and premature aging syndrome. So thank you all for a patient listening and have a good day.